I am live doing this week's Ask Me Anything. I'm proud of my t-shirt. It says I nap, and then there's a sloth, and underneath it says periodically. Yeah, it's sciencey. I like it. I also nap. Hello and welcome. I have 1, 2, 3, 4, 5, 6, 7, 8 questions already, but I will also answer any questions that you have. Place them in the comments anytime, and I will just keep an eye out and answer you. First question that I got is this is not in any order. In fact, this might be the last one. I might be going in reverse, but never mind. It's the first one on my piece of paper. What do I think about gastric bypass and gastric sleeves? What a question. This person's asking me my opinion, so I'm going to share my opinion. Weight loss surgery is a very hot topic. It's a very contentious subject, and the most important thing I want to say is that you get to decide what happens to your body. You should have full bodily autonomy, and you should have agency to act on that autonomy. So you should be able to choose what you want to do to your body, and in order to make a choice you need to know all of the facts, you need to know all of your options, you need a place to discuss them, ask questions, etc, etc. So that's very important, and you need to have the power to be able to make those choices. There's no good saying you can make a choice, but if you don't do it, then we're not going to do your knee surgery or sort out your endometriosis or etc, etc, because of course that I didn't realise that I can answer the questions. That's exciting. So just learned something on Instagram. Anyway, what do I think about gastric bypass and sleeve surgery? So you need all of the information, and the information that I will tell you is, number one, it doesn't last. All of the evidence nowadays is suggesting that you need to have a second op. And according to one study that I've read recently, that should be around the 7-year mark. So it doesn't last, no matter what they say. It doesn't. You start to regain weight, and after about 7 years, you probably need a second surgery. The second is that it has numerous side effects that are not discussed routinely. So 10% of people will develop gallstones and need an operation. More than 10%, I think it's 15%, will develop ulceration throughout the gastrointestinal tract. Gastroparesis, malnutrition is almost inevitable, all sorts of things like that. So you need to know all of those side effects before you make a choice to have weight loss surgery. And then you also need to know that it hasn't been demonstrated to improve I've seen your comment, by the way. It hasn't been demonstrated to improve your health. So, for example, people say you need to have weight loss surgery in order to manage your diabetes. Has it been shown to manage diabetes, whatever that means, in the long term? No, it hasn't, unfortunately. You might see in the short term, in the first, second, maybe third years, a reduction in your HbA1c. Maybe even you go into remission, but it's not long-standing, it's not long-term. There's no evidence actually to support that weight loss surgery will improve your health and your health conditions in the long term. So that's a little brief summary of what I think you need to know about weight loss surgery, or what I think about. So that was the question. What do you think about weight loss surgery? If you want to know more, I have a webinar on it. I have a masterclass on it, and you can find that on my website. The next question is, are you really a doctor? Yes, I am. I went to medical school at Barts in the London Medical School, to be precise. I graduated in 2003. I have been a doctor ever since. My GMC number is 6077567. Feel free to look me up on the GMC register. Contrary to popular belief, I have not lost my licence to practice. I have given up my licence to practice temporarily, or for the moment, because quite frankly I have better things to do with my life, but I have not lost my licence, and I can regain my licence whenever I want to. So there you go. Right, there are some questions here which I'm going to address. Hi, I honestly need to lose weight. Okay, a serious amount. All right, 20 kilograms. That's a lot. That's what, 50 pounds? I've developed diabetes type 2 now. Yeah, me too. I tried Ozempic and hated it, as well as it didn't work. Yeah, I'm not surprised you hated it. I'm 64 and every time I lose, I put it back on. Of course, because, you know, you're a human being. That's what happens. So the first thing I want to address is I honestly need to lose weight. I understand why you think that. And I'm not saying you don't. I'm not saying you shouldn't. Sorry. I'm not saying you shouldn't. I don't think you need to. I disagree with that statement. I don't know who's telling you that you need to, but I disagree. Now, if you want to, that's different. I want to lose weight is my body, my choice. I respect that. I need to implies that someone has told you that you need to, and I disagree with that. Now, you've set yourself quite the goal, 20 kilograms, that's a lot. That's a lot of weight. And the reason I'm worried about that is because, as you've learned yourself, every time you try to lose weight, you will regain it. So two things happen. Number one, each time you go to lose weight in the future, it'll be harder and harder. And that is because your body's natural response to restriction, whether it be because you're on medication or you have a surgery, or because you're just, you know, reducing how much you eat. Your body's natural response is to put all sorts of things into place. For example, interfering with your basal metabolic rate, interfering with your muscle and fat storage, interfering with your genetics, interfering with your gut. And some of those interferings are long-standing. So the next time you try and lose weight, you're going to have to do even more extreme things to lose that weight. And anyone, even if you've had weight loss surgery, a lot of people are like, I had weight loss surgery, I've gained it all back now, I have to do something even more extreme to lose the weight. So it's because of that, the fact that it's going to be hard for you to lose weight, you'll probably have to resort to some extreme measures. And if you succeed, it's almost inevitable that you're going to regain it, especially because you've got insulin resistance. Because of that, you're going to weight cycle. And if you drop a little bit of weight and regain that little bit of weight, it's not great. But if you drop a significant amount of weight, and 20 kilograms is a significant amount, and then you regain it, that actually has very, very negative impacts on your health, including worsening your diabetes. So I understand that you feel that you need to lose weight. I'm not saying that you shouldn't. I'm just questioning whether you do, and whether weight loss is actually going to make things worse rather than better. Now, that's a complicated conversation. Please feel free to book a discovery call with me to chat it through if you want some more information. I obviously can't do that over this live, yeah, let me know. Somebody has said that you're 5'9", 240, I don't know what that means. I don't work in pounds, and also I don't know whether that means that you're fat or not. But anyway, feeling strong, yes, but had to give up my dog. Is that like, I'm not sure how that's related, but I'm sorry to hear that, because I fucking could not give up my dog. Going back to the original question, your doctor told you needed to. Well, your doctor is wrong. Well, it's not that your doctor is wrong. So that's a very simplistic view of things. But as I said, feel free to get in touch. And yes, some very helpful comments here. 20 kilograms seems far too much for anything. And I agree with that completely. And also someone has said, you are allowed to decline to speak on your weight with your doctor. Yes, I have a script that you can download. If you go to my stories, just click on it, download it, and you've got a script. And on that script, you can literally read out something that will prevent your doctors from discussing your weight from you any further. And I know it's hard when you're diabetic. That's why I'm offering a diabetes package. In fact, I'm talking about it a lot, about the diabetes package. So why don't you have a look and see whether that's something that will interest you? Because I do a lot of education on diabetes, and I do like a 90-minute one-to-one where we cover everything. And honestly, by the end of it, you will have a very, very different idea of how to manage your condition and whether or not you need to lose I'd encourage you to have a look at that stuff. As I said, it's in my stories. Right, no more questions yet, but please add them as you want to. Are you actually a doctor? I did that one. Okay, a really, really good question. I'm so glad this person asked this question. I need some advice on how to clean a deep navel on a fat stomach. It's stinky and embarrassing. Thank you for asking that question, because this is something that we don't talk about. I love fat bodies. I really do. I'm a fan of a fat body. But we need to learn how to take care of our fat bodies. You know, when you're growing up, somebody usually teaches you how to clean your teeth, how to maintain body hygiene. If you are a female, how to manage your periods, and you know what sanitary towels, sanitary products are available to you. Like we have these conversations, right? And hopefully, it's the most important adults in our life. It's our parents, but if it's not a parent, it might be a teacher or an aunt or somebody who is able to teach you these things. Nobody sits you down and goes, "This is how to care for your fat body," and I think we should be doing that. One of the things we have to understand about fat bodies is that there are certain your folds are prone to skin conditions if you don't manage them properly, if you don't look after them properly, and one of those skin conditions is a condition called intertrigo. intertrigo, intertrigo, and it's a kind of a redness. Sometimes you get like a slightly like yucky kind of discharge, not discharge, that's not what I'm looking for, like a kind of like almost like a sort of creamy stuff. How best to describe it? A bit creamy. Sometimes people say it's a bit cheesy. It smells a bit cheesy, and you can get like a little white scale. Look it up, intertrigo. It can be treated very easily with a combination of antifungals, an antifungal cream, which should do the trick. But I actually tend to prescribe antifungal in combination with a low dose steroid. So in the UK we have something called Dactacort, which is mild hydrocortisone cream, and miconazole, which is the antifungal. And you can use that, and you can usually treat that, and you can do that over the counter, or you can speak to a pharmacist about it, or you can just Google it, go onto the NHS website or whatever website you use, and it should explain how to manage intertrigo. Take care of your skin by making sure you dry those folds, right? Come out the shower, dry in between all of those folds. Don't wear too much restrictive clothing, especially when you're at home and you can relax. Try to wear loose clothing. Make sure that your clothing is not too restrictive, because that can worsen intertrigo as well. Now, that might not be what's going on with your navel. Sometimes you can actually get a bacterial infection inside your belly button. And if that's the case, again, it's probably just an antibacterial antibiotic cream that you need. But you'd need to go and see a GP about that, because that would need to be prescribed. Or at least, if you live in the UK, go see a pharmacist, because your pharmacist may well be able to manage that rather than having to go and see a GP. Right, there's more questions. Oops. Oh. Right. I have a genetic form of dilated cardiomyopathy, and in the future I might need a heart transplant. I can only get a new heart when I lose weight, so I think I really must do it. But how? Okay, I hear this. This is a really tricky situation. So here's a person who has a congenital condition. You have a congenital condition. That's nothing to do with anything. You were just born that way. And you may need a heart transplant in the future. It's not definite, but it may happen, and you're aware of that. And at the moment, you're not entitled to one because of your weight. And that's disgusting. It is, I would say, just active discrimination. I don't think that there's any other way to describe that except for discrimination. So you're in one of those impossible situations where you're like, I have to lose weight, otherwise I can't get that heart. And if I can't get that heart, terrible things will happen. And so what I would say to you is that losing weight is hard in of itself. Sustaining weight loss even harder. So you don't actually need a heart transplant right now. If you were to try to lose weight now, chances are you will regain that weight within 5 years. That's what all the studies show. Well, 2/3 of people actually end up heavier than when they first started. So if you try to lose weight now, what you'll find is that you probably end up heavier and heavier as time goes on. So that by the time and I should say if, not by the time, because we don't know if it's going to happen, but if it comes to the stage where you need a heart transplant, you may be even heavier than when you first started. If you don't try to lose weight, chances are you will maintain this weight that you're currently at. And in doing so, if they say to you, you know what, you can't have this heart transplant unless you lose weight, then you make that decision at that time, not before. Don't forget that a lot of people who end up needing heart transplants would have lost a ton of weight prior to needing the heart transplant. Again, we're hoping that never happens to you, right? We're hoping it never happens. But I feel like there's nothing that you could do, statistically speaking. The chances are anything you try and do now is going to make it worse rather than better. Even if you said, I'm going to do weight loss surgery, so that drops your weight quite significantly. As I said, weight tends to creep up, and a lot of people have regained all the weight within a decade or so. So I don't know what to tell you, because I know it's a really difficult situation. But what I do know is that chances are you will regain any weight that you lose, and actually 2/3 of people end up heavier once they've regained that weight, and that's not something you want to do in your case should you need a transplant down the line. I hope that helps. Because of my knee problems, I've been able to walk without a brace, and taking them out long was too much for my body. Oh man, oh that sucks so much. Like, I couldn't lose my dog. So I hear you, and again, this is a real problem. People who have knee problems, and if they have a larger body, so higher weight people with knee problems are often really badly treated. They're getting absolute subpar healthcare, and as a result, life changes, and you've got, you lose a pet that is so important to you, and that's not good enough. It really isn't. Again, this is why I love working one-to-one with clients. When I was working as a GP, first of all, I had no control over who I saw, right? Like it's not like you get to control that unless you're a private GP, and I had no interest in being a private GP. And on top of that, you don't get to do the weight inclusive stuff. Like, you are kind of forced into following a weight-centric approach to medicine. And I wasn't prepared to do that. Now I work with clients. Yes, I'm not their actual doctor. I can't prescribe drugs. I can't order tests. I don't have the kind of some of the capabilities that I had when I was a registered doctor. However, I am able to diagnose, or I can't diagnose because I'm not your medical doctor, but help you to understand your symptoms, your medical condition, how to manage your medical condition, and to make sure, and this is the important point, to make sure you're getting the healthcare that you should be getting. Because I don't know about you, every client I've ever worked with, I'm like, hang on a second, that's not right. Doctors are getting away with it because often people who are higher weight and existing in a marginalised body don't have much of a choice. So that's why I'm here. If you are really struggling with your knee and you need some support, again, book a discovery call. There's nothing to lose from booking a discovery call. I'm so sorry to hear about that shame. I talk about this shame quite a lot. In fact, did I send it today or I'm sending it tomorrow? There's a newsletter, there's an email coming out either today or tomorrow about shame, where I talk about my shame. Because we all feel it, and shame and fear have no place in healthcare. I've said this over and over again, but my goodness, they run rampant in healthcare. So of course you're deeply ashamed, but you don't need to be deeply ashamed. You really don't. You've done nothing wrong. And as I said, I would love to be able to work with you. A question about the fungal cream. As I said, any antifungal cream you can buy over the counter, but speak to a pharmacist. They should be able to advise you. But a fungal cream in combination with a mild steroid might be a better option for Intertrigo. I'm not sure about the small changes in routine. As I said, that's not the advice I'd be giving you. When you come and see me, I don't talk to you about exercise and diet because I don't need to. I can do an entire consultation and help you sort out your life without ever bringing up what you eat or how much exercise you do, and it's fantastic. So you don't need to worry about that. Hello, my friend. It's good to see you. I wonder about water intake and fat bodies. I already don't drink enough, especially managing brain fog and ADHD. So there's a big thing about water. If you have ADHD, and if you're neurodivergent, I should say, you're probably not so good at picking up cues. So you're probably not good at picking up hunger cues, and you're probably not good at picking up thirst cues. So as a result, you will probably not be drinking enough. And that's not your fault. It's just that your body's not telling you that you're thirsty. We should be drinking every time we feel thirsty. But if we're not picking up the cues, because we're hyper-focusing, or because we literally cannot detect them, we cannot process them, or because it's unlearned behavior, right? Because drinking and eating kind of go together a lot. And so, you know, I don't know, for a long time I was told like you have to drink every time you're hungry and all this nonsense. So there's like some messed up feedback loops in my brain now. So I don't want you to punish yourself for not drinking enough, but I do think it's good to, if you do have neurodivergent, if you are neurodivergent, to keep an eye on how much you're drinking. Have one of these like stupid water bottles with the, you know, and just keep an eye out. I don't think you need to do anything as different because of your weight. You don't need to drink more or anything like that. You just need to drink an adequate amount of water and if fluids. And if you live in a hot climate, then you have to be even, you know, because you're sweating, you need to drink even more. Also, I've thought about gynecomastia to reduce chest size, but I'm told that I must be at my perfect weight before doing the surgery. Yeah, so any breast reduction or any kind of so that applies to all genders. They have really strict rules in place because, and you know why that is? Because the surgeon doing it doesn't think that it will look good enough on a fat body. There's no reason. There's literally no reason. Just, you know, I want a pretty picture at the end. There isn't any evidence that, you know, that it's not safe or anything like that. It's a very routine procedure, maybe slightly increased risk of infection, but absolutely can be mitigated. This is purely a cosmetic thing, this bullshit, literally, on the part of your doctor. Right. Hello. There's somebody in the midst who wants to talk about the systematic review of O'Brien found an average excess weight loss of about 50% after 20 years. So where do you get your info about it not lasting? Well, first of all, it's 50%. It's not great odds, is it? You're going to mutilate your stomach and there's a 50% chance that it will last. Second of all, there's more than one study. So, you know, you might want to maybe ask around, look around. I'm getting my information from the most up-to-date studies. And as I said, most gastric, I mean, if you actually bother to read the studies, most gastric bypass surgeons and most bariatric surgeons now are agreeing that weight loss, it's not that everyone regains the full amount, I should point out, but that weight loss is not sustained. It's a well-accepted fact if you look at any of the recent literature. So yeah, one study's not going to suddenly change my mind. Thanks for that. Right, where are we at? I've got some more questions. Oh, by the way, the trolls have found me, and that's fine. Can I name a study? No, not off the top of my head because I have more important things to do. I will kick you out if you don't be quiet. Yeah, thanks. I'm glad. I'm not engaging in this conversation further. And if you want to have a debate with someone, go find someone else. I'm not doing that with you. If you want the actual information I've got all of my literature searches and all of my research in my masterclass, which is behind a paywall. Feel free to pay for it. What do you do when, and I'm content warning, gastric bypass patients also have a significant chance of substance abuse. That's one of the many side effects. As I say, I cover it all in my masterclass. This is a question from a troll. What do you do when, content warning for language, obesity is the actual cause of your patient's symptoms? Oh, that's really easy because it never is. There literally is no evidence that it ever is the cause for my patient's symptoms. So what do I do? Well, I, do my job. Simple. Here's a good question. Can you reverse type 2 diabetes and be a non-diabetic? I love this question because I think it's two parts. The idea of being able to quote unquote reverse type 2 diabetes. There isn't a kind of experts don't agree exactly on what it means to reverse diabetes, but for the most part, it means that you no longer have a HbA1c over 6.5% or 48, depending on which numbers you use. And so you're under the thing, and actually some will say you have to be under, 5.6 Some will say that you have to be under 6. Some will say that you have to be, is it 6.5? I can't remember if it's 6 or 6.5, guys. I'm really sorry because I work in the units, the different units. So forgive me for getting the units wrong. But basically, underneath the diabetic threshold, you have to get below it. And some say underneath the quote unquote pre-diabetic threshold. Those of you who know me know that pre-diabetes is not a real condition, but you know what I'm talking about for the purpose of this. So can you reverse it? And you have to be able to do that without being on medications. So without any medications, you can get your HbA1c under the threshold. That's what we mean by reverse type 2 diabetes. Can you do it? Yes, absolutely. Plenty of ways to do it. Starving yourself is probably the most effective way to do it. And so there was the direct study where they used a very low calorie diet. I think it was less than 800 calories a day, meal replacements for, I believe it was 3 months. And then they followed these diabetics over a period of 5 years. And yeah, I think in the first year, like about 50%, roughly half of them managed to reverse their diabetes. And guess what? Didn't last. By the end of the 5 years, I think it was 11 out of the original 300 had managed to maintain their reverse diabetes. So it is possible to reverse your diabetes. It is almost impossible, not impossible, not quite, but it is highly unlikely that you'll be able to maintain that reversal. And there are other studies that have shown that those who are able to reverse their diabetes and sustain that reversal, it's very early onset. You have a very low HbA1c to start with. In fact, one could argue maybe not really diabetic to begin with. Or if you are, it's very, very mild diabetes. So it is possible, but it's unlikely for many people, and certainly not sustainable for the majority of people. If you're in reversal, does that mean you are no longer a diabetic? So to be a non-diabetic, so reversal of diabetes or remission of diabetes is what we call it. Remission of diabetes is not the same as not being a diabetic. The only time you can go from being a diabetic to not being a diabetic is if the diagnosis was wrong in the first place. And I really want to point this out because I have seen this happen time and time again. The definition of diabetes, type 2 diabetes, or any diabetes, beg your pardon, the definition of diabetes is a sustained hyperglycemia, sustained high levels of glucose in your blood. What that means is you can have a temporary spike in your blood glucose levels and not be diabetic. And sustained means over a period of 3 months. And the reason this is problematic is because HbA1c, which we are doing routinely now in a lot of people, measures your blood sugar over a period of 3 months. So you could have had a temporary spike in your blood sugar and then it came back down again, but your HbA1c remains high. And if that one HbA1c is the only thing that has been used to make your diagnosis, to make a diagnosis of diabetes, you have not been diagnosed correctly. You have been misdiagnosed. You need to have two separately raised HbA1cs over a period of 3 months, or a raised HbA1c and separately, so it has to be sustained separately once there's no illness or anything that could be causing it. You also have to have a fasting blood glucose over a certain level, okay? There needs to be 2 separate readings, and they can't be 1 week after another because sustained, right? So this is really important. So you're to the troll, I'm genuinely just interested. Clearly you're not genuinely just interested. Hiding yourselves behind a paywall, blah, 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 blah. All of a sudden people have changed. Right, I'm going to start kicking now. Like, how do I get rid of you? Remove from live video. Bye-bye. And how do I'm not a woman. Ollie, not a woman. Thanks. Block. Bye-bye. Please listen to actual doctors. I am an actual doctor's. Bye-bye. Get a hobby. Go to work. I think I blocked you, didn't I? Yeah. Okay, right, I've got rid of them now. Jeez, these people are really, do they not have anything better to do? Oh, look, what these trolls. Okay, so, where am I? I've lost my thought now because I was blocking trolls. So can you reverse type 2 diabetes? You mean go into remission? Yes. Be non-diabetic unless you were misdiagnosed? No. Right. Next question. So I think there's one in the. Saw something before the trolls. Can you have an underactive thyroid even if your thyroid bloods fall within the normal range? Ooh, good question. It depends if you're on treatment or not. So it's like with diabetes, because it's all hormones, right? When it comes to the endocrine system, there's a difference between temporary stuff and permanent stuff. Sustained versus not sustained. So some people can have a temporary abnormality, like temporary changes in their thyroid hormones. And we measure two thyroid hormones. One is like your free thyroid hormone, your T4, and the other is your thyroid stimulating hormone, which is actually the secreted by the brain. And usually the thyroid stimulating hormone, the TSH, is the more reliable result. So if you have an abnormal TSH, then or you have a TSH that is literally heading towards the abnormal rate. So in the case of underactive thyroid, it will be like right at the top, like within the normal range, but like right at the top. Then yes, you can have an underactive thyroid. And if you already have an underactive thyroid and you are on thyroid replacement hormones, then sometimes your results can be quote unquote normal, but you can be symptomatic. But other than that, no, that was a very complicated answer, but it's a tricky question to answer. I'm trying to think if I have any resources on thyroid. No, I probably need to do one, don't I? I probably need to do a thyroid workshop, thyroid masterclass. Something to put on my list of things to do. Right, is there a correlation between BMI and issues like type 2 diabetes and heart disease? Again, this was not a genuine question. This was another troll. Google it. Is there a correlation? Yes. So, I don't know what point you're making there, but whatever. Is Ozempic good for type 2 diabetes? That's a serious question. Yes. Is Ozempic good? Good's a tricky question. I know it's Instagram, so you're not able to explain exactly what you mean by that, but Ozempic is a treatment for type 2 diabetes. It's existed for probably not quite 20 years yet, about 15 years. It is very good at reducing insulin resistance, so improving insulin sensitivity. It also, unfortunately, causes a suppression in your appetite. So you tend to reduce how much you eat, you therefore tend to lose weight, which is unfortunate. And then it can cause all sorts of other nasty side effects as well. Gastrointestinal ones are the most common ones, like nausea, vomiting, diarrhea, that kind of stuff. So it has side effects, all drugs do. It is effective in some cases. It's not always going to work. Some people take it and it doesn't work great for their blood sugars. Others take it and it works beautifully. It kind of depends. Is it good for diabetes? It is one of the 6 groups of medications that we have for diabetes. Ozempic is a GLP-1. If you want to try a GLP-1, you don't have to use Ozempic. Ozempic has some of the strongest side effects in terms of the like reduction in your appetite, which I said is really problematic, and it's actually very distressing, and also there's gastrointestinal side effects as well. So doctors often want to plug Ozempic because it causes weight loss. Weight loss has not been shown to be effective in improving your diabetes in any way, shape or form. In fact, interestingly, when you look at the long-term data, weight gain doesn't seem to have any impact on your diabetes either. Thanks, my love. That was such a lovely comment. What I would say is, if you want to try a GLP-1, if that's one of the medications that you'd like to try, you don't have to take Ozempic. You could try one of the others. I have a list of them somewhere on my website, all the different GLP-1s you could take. Just Google them. There's one called Trulicity, which is once weekly. That doesn't cause as much weight loss, which is why people don't like it anymore, but it works fine on your blood sugar, so you could try Trulicity. I have heard with Trulicity, I've never tried taking it, but I have heard several people say it's very painful to inject Trulicity, and I don't know if that's true, but I have heard that. And there are other ones. There are once a daily ones like Victoza. There are all sorts of different ones. So you could try a GLP-1 that isn't Ozempic if you can't get on with the side effects of Ozempic. The other thing is, with Ozempic, if you're taking it for weight loss, first of all, it's not licensed for weight loss. You should be taking Wegovy for weight loss, which is 2.4 milligrams of semaglutide, as opposed to Ozempic, which is a maximum of 1 milligram of semaglutide. And if you look at the step 2 study, which compared 2.4 milligrams with 1 milligram, you will find that 1 milligram of semaglutide has much smaller different impact on weight loss than 2.8 2.8, 2.4, 2.4. 1 versus 2.4. So really, if you're taking something for weight loss, you should be taking Wegovy, not Ozempic, because the studies have shown it's not that effective. But if you are taking Ozempic for diabetes, you're going to take the lowest dose that you need. So the lowest dose possible to manage your blood sugar without causing too many side effects, one of the side effects being weight loss. So that's the other thing. If you're going to take Ozempic, take it at a low dose. Don't let them pressure you into taking it in a higher dose. Again, for those who've just joined, I offer a diabetes package where we go through all of the medications, I explain all of the different ones, all of your choices, and then you have all of the information, because I know that doctors are not great at doing this. Right, so unless we have any more questions left, I have one more that I was given, and I really like this one. I wanted to get round to it. What is your view on BMI for Black and minority ethnic people? So there's two things I want to talk about with this question. The first is BMI cannot be used on Black and minority ethnic people. It shouldn't and cannot really be used, because all of the data with which we based BMI levels on, all the data that the WHO based their arbitrary cutoffs on, was done on white people, white Europeans. So it's not appropriate to use BMI if it's not actually been tested on people who are not white Europeans. It also has an extremely racist history. The person who first came up with, it wasn't BMI at the time, it was just looking at height and weight, but that was Adolf Quetelet, and he was a eugenicist. And so it has a very racist history. Now, that's the second thing I want to get down to, though, is that the racist history did not end in the 19th century. BMI is used as a tool of oppression against Black and minority ethnic people today. It's also used as a tool of oppression against fat people, against trans people, against any person who lives in a marginalised body, but especially against Black and minority ethnic people, because it's not appropriate to use it. Studies have shown that Black and minority ethnic people tend to have an average of a higher BMI. It's not because they're fatter, it's just because their weight and height and differences in Black and minority ethnic people's bodies mean that BMI doesn't apply to them, and yet is used against them. In fact, if you look at a lot of things, so for example, the criteria for giving people Wegovy, for pushing Wegovy onto people in the UK, is like you have to have a BMI over 35, unless you're a Black or minority ethnic person, and then you can have an even lower BMI because you're quote unquote higher risk. And I'm not saying that it's necessarily a bad thing. Like at one point in time, I was really enjoying being a fat person because it meant I got priority COVID vaccines, and I was like, I'll take it, it's fine. But we are using BMI to punish Black people, to force medications onto them that are not necessary, to deny Black people treatments, managements, etc., etc. And also in the kind of, like, if you zoom out kind of globally, we are using BMI as a tool of oppression against anyone who is not a white European, and that's not okay. So I have very strong views. About BMI. I don't use it. I don't believe anyone should use it. In fact, I think it's pretty well clear now that nobody should be using it. But I think that we also have to reconcile the fact that BMI has been used as a tool of oppression and continues to be used as a tool of oppression against marginalised groups, in particular Black, Brown, Indigenous people. And therefore, we have a lot of work to do to fix the damage that we've done. Does that make sense? I think that's a really good place to stop. I hope you found this AMA helpful. To the person who is struggling with your type 2 diagnosis, please reach out. Like, you know where I am. Please reach out. To all the trolls, fuck you. And I'll see you all next week. Take care. Bye.